Welcome back to the deep dive.
Hi there.
So today we're doing something a little bit different. This session, this deep dive, it's really specifically designed for you.
That's right, especially if you're in the middle of MSRA revision.
Exactly. We're diving into your revision notes on a really crucial topic. Hereditary hemorrhagic telangiectasia.
HHT for short. Much easier to say.
Definitely. Though you might also see it written down as Osler-Weber-Rendu syndrome.
Or Rendu, Osler-Weber disease, yeah. It's named after the physicians who first described it, way back. But HHT is the term everyone uses now.
Good. HHT it is. So what's our goal today?
Simple, really. We want to pull out the absolute must-know, high-yield info from these notes.
Make it straightforward, easy to remember, and really highlight what's essential for the exam.
Exactly. It sounds complex, but the core ideas are definitely manageable. It's all about this genetic thing affecting blood vessels.
Okay, let's dive in then. What exactly is HHT? Define it for us.
Right. So at its absolute core, HHT is an inherited disorder, a genetic one, and it leads to abnormal blood vessel formation, basically all over the body.
Inherited. You mean like passed down?
Yes, specifically, it's autosomal dominant.
Autosomal dominant. Refresh our memory. What does that mean practically?
It means if one parent has the faulty gene for HHT, each child they have has a 50% chance of inheriting that gene too. 50-50 shot every single time.
Wow, okay, 50%. That's significant for families thinking about genetics. So this abnormal vessel formation, what does it actually look like? What are the signs?
Well, the most visible signs are usually these things called telangiectasias.
Telangiectasias.
Yeah, they're like tiny dilated blood vessels. They look like small red spots, sometimes a bit like spider veins. You often see them on the skin or like inside the mouth, on the lips.
Okay, small red spots.
Yeah.
But you mentioned it affects the whole body.
Exactly. And that's where the perhaps more serious issue comes in. Arteriovenous malformations.
AVMs.
AVMs, right, I remember these, where arteries connect straight to veins, skipping the capillaries. You got it. They bypass that normal capillary network. And in HHT, these AVMs can pop up in major internal organs, lungs, brain, liver, gut.
And that sounds like where the real danger might lie.
It certainly can be. And it all traces back to genetics.
Which genes are we talking about?
Mostly mutations in genes called ENG
Yeah.
that causes HHT type 1, and another one called ACVRL1, which you might also see as ALK1, that's linked to HHT type 2.
ENG and ACVRL1.
Yeah, these genes are normally involved in like sending the right signals for blood vessels to develop properly. If they're mutated, the instructions get messed up.
You mentioned inheritance, but I think I saw something about cases popping up out of the blue. No family history.
Yes, that's a really key point, actually. While most cases are inherited, something like 20%, maybe 1 in 5, are thought to be de novo mutations.
Meaning spontaneous?
Spontaneous, exactly. A new mutation in that person. So you can't just dismiss HHT if the patient says, oh, no one else in my family has this. It still needs checking out.
20% is pretty high for spontaneous. Okay, so faulty genes mean faulty instructions. What's actually going wrong in the vessels themselves? The pathophysiology.
Okay, think of your normal blood vessels like, I don't know, really well-made pipes. Strong, smooth flow, good connections. You've got the high-pressure arteries leading to the tiny capillaries and the filter system then into the low-pressure veins.
Right. Makes sense.
In HHT, because of those faulty gene instructions, the pipes aren't built right. They end up being more fragile, kind of disorganized structurally.
Weaker,
yeah, and prone to dilating and leaking.
Yeah.
This gives you the telangiectasias near the surface. And deeper down, you get those AVMs, which are like these direct high-flow shunts. They completely bypass the capillary bed.
Ah, bypassing the filter.
Exactly. And that structural weakness is why they tend to bleed easily.
Okay, that leaky, fragile pipe analogy helps. So, risk factors. Given it's genetic, the #1 risk factor is family history.
Absolutely. If you have a first-degree relative, a parent, sibling, or child with HHT, your risk is significantly higher. So asking about family history is critical if you suspect it.
And it affects everyone equally otherwise, age, gender, race.
Pretty much, yes. The genetic risk is there from birth if inherited. Symptoms might start at different ages, but the underlying condition doesn't discriminate based on race or gender.
Okay. Now, this is important for exams. HHT can cause things like skin spots, nosebleeds, internal bleeding, but other conditions can cause similar things too, right? What else needs to be on our differential diagnosis list?
Yes, super important. You need to think about what else could this be. So other vasculitis disorders, conditions where blood vessels get inflamed, could be considered.
Like SLE, lupus.
SLE could be on the list, yeah, although the skin signs are usually a bit different. Also, think about acquired telangiectasias.
Acquired meaning not genetic.
Exactly. You can get telangiectasias from things like too much sun exposure over years, certain medications, or sometimes with chronic liver disease. They look similar superficially, but the cause is totally different, not inherited.
Okay, so rule out the acquired causes. Any specific syndromes to keep in mind?
CREST syndrome is a classic one to remember. It's an acronym. Calcinosis, Raynaud's, esophageal dysmotility, sclerodactyly, and T. telangiectasia.
Ah, the T is for telangiectasia.
Right. So it has telangiectasias, but it's part of a different autoimmune condition, scleroderma spectrum. It's a differential for HHT, not HHT itself.
Good distinction. CREST is a differential. Anything else?
Well, because bleeding is such a big feature of HHT, you should also consider other primary bleeding disorders, like von Willebrand's disease, for example.
Okay. Now, just to clarify something, the notes mention things like GI bleeding, lung AVMs, liver issues later on. These aren't differentials, are they? They're part of HHT.
Exactly. That's a brilliant clarification. Those are manifestations or complications of HHT. They happen because of the HHT blood vessel problems in those organs. If you find, say, a pulmonary AVM, you should think, could HHT be the cause? Rather than thinking HHT is a differential for the AVM. Makes sense.
Yes, perfect. So how common are we actually talking here? Is this something we'll see a lot?
Not really common. It's classed as a rare disease. Estimates vary a bit, but in the UK, it's probably somewhere around 1 in 5,000 to maybe 1 in 10,000 people.
1 in 5,000 to 10,000.
Yeah, globally, maybe similar, 1 in 5,000 to 8,000 perhaps. So because it's relatively uncommon and the symptoms can be quite varied, it does unfortunately sometimes get missed or diagnosis is delayed.
I mean, it affects all groups, though there was that interesting note about higher prevalence in specific populations, like Afro-Caribbeans in Curacao.
Yes, that highlights how specific gene mutations can become more common within certain founder populations. It's a fascinating bit of epidemiology.
Okay, let's get to the clinical features. If we suspect HHT, how does it actually present? What are the classic symptoms we should be looking for?
The number one most common symptom, and often the first one to appear, is recurrent nosebleeds. Epistaxis.
Nosebleeds.
Yeah, and typically starting quite young, often in childhood or the teenage years. And they can be pretty frequent, sometimes severe. So a young person with lots of unexplained nosebleeds, HHT should definitely be on your list, especially if there's any family history.
Nosebleeds, starting young. Got it. What about the telangiectasias, those red spots?
So those are also classic, but they often tend to show up a bit later, maybe in the 20s or 30s. You need to actively look for them in the characteristic places.
Which are?
Lips, inside the mouth, on the tongue or gums, fingertips, sometimes the face or ears. They typically blanch with pressure, meaning they go white for a second if you press on them.
Okay, lips, mouth, fingers, blanching spots.
Yeah.
And the internal AVMs, how do they show themselves?
This is where it gets really variable, depending on which organ is involved. This is super high yield for MSRA. Pulmonary AVMs, the ones in the lungs, they can cause shortness of breath, especially when exercising. Sometimes chest pain, or even low oxygen levels, because blood is shunting past the oxygen-exchanging parts of the lung.
Okay, lung AVMs cause breathing issues. What about elsewhere?
AVMs in the GI tract, so stomach or intestines, can cause slow, chronic bleeding that often isn't obvious. Patients might just present with iron deficiency anemia.
Hidden bleeding leading to anemia.
Exactly. And then brain or spinal AVMs, they can cause headaches, seizures, neurological deficits like weakness or numbness, or potentially catastrophic bleeds like a stroke.
Wow. Okay, so the presentations are really diverse depending on where the AVMs are.
Totally. Which brings us neatly to the diagnostic criteria, absolutely essential knowledge. The Curacao criteria.
Right, the Curacao criteria. These are key for making the diagnosis clinically, aren't they?
Absolutely vital. There are 4 criteria. If a patient meets 3 or more, it's considered a definite diagnosis of HHT. If they meet 2, it's possible or suspected HHT and warrants more investigation.
Okay, let's break them down. Criterion number 1.
Recurrent spontaneous epistaxis, those nosebleeds we talked about.
1. Epistaxis. 2.
Telangiectasis. Multiple, and in those characteristic locations, lips, oral cavity, fingers, nose.
2. Telangiectasis. 3.
Visceral lesions. This means evidence of those internal AVMs in the lungs, liver, brain, spine, or GI tract. You usually need imaging or endoscopy to confirm these.
3. Visceral lesions, AVMs. And the last one, number 4.
Family history, specifically having a first-degree relative, parent, sibling, child who meets these same criteria for HHT.
4. Family history. Okay, so epistaxis, telangiectasias, visceral lesions, family history. Need 3 for definite, 2 for possible.
You got it. How about that mnemonic ET visited family? Epistaxis, telangiectasias, visceral family. Does that work?
ET visited family. Yeah, that's pretty good, actually. Okay, let's try a quick case. Say a 16-year-old comes in. Nosebleeds multiple times a week, started at age 14. On exam, you spot a few tiny red dots on their lips, couple on the fingertips too. Mom mentions her own sister, the patient's aunt, has always had bad nosebleeds and had some lung procedure years ago. How are we scoring this with Curacao?
Okay, let's see. Recurrent epistaxis, yes. Criterion 1 checked. Telangiectasias on lips and fingers, yes. Criterion 2 checked. Family history. Okay, it's an aunt, which is a second-degree relative, but she has symptoms suggestive of HHT, including a potential visceral lesion. Technically, the strict criteria say first-degree relative for point 4.
Okay, so only 2 definite criteria there, epistaxis and telangiectasias.
Based strictly on the Curacao definition, yes, that would put them in the possible HHT category needing more investigation. However, clinically, with that strong suggestive family history, even in a second-degree relative, your suspicion would be very high. It highlights you still need clinical judgment. If the mother had the history, it'll be 3 points, definite HHT.
Okay, good nuance there. The criteria are guidelines, but the clinical picture matters. So once HHT is suspected, maybe meeting 2 or 3 criteria, how do we confirm it and figure out the extent, especially those internal AVMs?
Right, so the clinical criteria get you started. To confirm and stage it, you need investigations. Sometimes capillary microscopy of the nail folds is mentioned as a screening tool looking for abnormal vessel patterns, but it's not definitive.
What about the internal stuff, the AVMs?
Imaging is absolutely key. For the lungs, a contrast-enhanced CT scan, often called a CT pulmonary angiogram, or sometimes a specific bubble study echocardiogram, is used to find pulmonary AVMs.
Okay, CT for lungs. Brain.
MRI is usually preferred for detecting brain AVMs. For the GI tract, if you suspect bleeding, endoscopy like gastroscopy or colonoscopy might find telangiectasias or AVMs there. Liver AVMs often need specific Doppler ultrasound or CT MRI protocols.
So targeted imaging based on suspicion and screening protocols. What about genetics?
Genetic testing is really important. It can confirm the diagnosis by finding the specific mutation in ENG, ACVRL1, or sometimes other rarer HHT genes.
And that's useful beyond just confirming for the patient.
Hugely useful. It confirms the diagnosis definitively, which can be helpful if the clinical picture is borderline. But critically, once you know the specific family mutation, you can offer targeted genetic testing to other family members. This allows for pre-symptomatic diagnosis, finding affected relatives before they develop symptoms or complications. That's massive for prevention.
Right, identifying people at risk early. Okay, so someone has a confirmed diagnosis. How do we manage HHT? What are the main goals?
Management is really multifaceted. The big goals are 1. Control symptoms, especially the bleeding. 2. Prevent serious complications from the AVMs. And 3. Manage any organ-specific problems that arise because of those AVMs.
Let's start with the bleeding. Nosebleeds, GI bleeding, causing anemia. What helps?
For the chronic anemia, iron replacement is fundamental. Or iron, sometimes IV iron if it's severe or not absorbed well. For nosebleeds, local measures are often the first line, things like nasal packing, cautery, burning the vessel, or laser treatment to seal off the bleeding points. Sometimes surgery like septodermoplasty is needed for really refractory cases.
Okay, local measures for nosebleeds, iron for anemia. What about the big internal AVMs? Lungs, brain.
These often need intervention to prevent rupture or other complications. Embolization is a cornerstone of treatment, especially for pulmonary AVMs.
Embolization?
Yeah, where an interventional radiologist guides a catheter through the blood vessels right to the AVM and basically blocks it off, often using tiny metal coils or a special glue. This stops the abnormal blood flow through it. Surgery might be an option too, especially for some brain AVMs, but embolization is often preferred if possible.
So physically blocking the AVM, are there medicines that can help the underlying vessel problem?
Yes, this is an evolving area. Antifibrinolytic drugs, like tranexamic acid, can help reduce bleeding frequency or severity by making clots more stable. They don't fix the vessel, but they help control the bleeding.
Tranexamic acid, okay.
There's also increasing interest in anti-angiogenic therapies drugs that interfere with new blood vessel formation, things like bevacizumab. These are typically reserved for more severe widespread disease or when other options fail. And then there's that interesting mention of hormonal therapy.
Oh yeah, the estrogen.
Estrogen, sometimes combined with progesterone, seems to help some patients, particularly with nosebleeds and GI bleeding. The theory is it might sort of toughen up the lining of the blood vessels, making them less fragile. Tamoxifen, a SERM, has also been tried. But you have to consider the side effects, especially in men taking estrogens.
Fascinating. Hormones affecting vessel walls. And I assume regular checkups are vital.
Absolutely essential. Ongoing surveillance, monitoring for anemia, and regular screening for those internal AVMs, typically brain, lungs, liver, according to established guidelines, even if the patient feels fine. Finding an AVM early, before it causes a stroke or a major bleed, allows for preventative treatment.
Makes sense. So with all this management, what's the long-term outlook? The prognosis?
Actually, for most people, if HHT is diagnosed and managed properly with regular screening and treatment when needed, the prognosis is generally good. Life expectancy isn't usually significantly shortened.
That's reassuring. But what determines the prognosis?
The main thing influencing long-term outlook is the presence, size, and location of those internal AVMs, especially in critical organs like the brain and lungs.
Ah, so it really comes down to the complications from AVM.
Exactly. The most serious complications and the things that can unfortunately lead to mortality in HHT are related to these AVMs. We're talking about severe uncontrollable hemorrhage or major events like stroke from brain AVMs or paradoxical emboli passing through lung AVMs.
Paradoxical emboli. That's clots bypassing the lungs.
Yes, small clots that would normally get filtered out by the lung capillaries can slip through a pulmonary AVM and travel directly to the brain, causing a stroke. Lung AVMs can also strain the heart over time, potentially leading to high-output heart failure or pulmonary hypertension.
So even if someone just seems to have mild nosebleeds and a few skin spots?
They could still have significant, potentially dangerous AVMs internally. The external signs don't always match the internal severity. That's a crucial take-home message.
Right, and the chronic anemia itself is a major complication impacting quality of life.
Huge impact. Constant fatigue, reduced exercise tolerance. It needs active management with iron, sometimes transfusions if severe, and cirrhosis from liver AVMs is mentioned as rare but possible.
Okay, this is all incredibly important stuff for MSRA. Let's try to quickly nail down the absolute core points again.
Okay, HHT, genetic autosomal dominant, think ENG, ACVR01 genes, causes abnormal fragile blood vessels, telangiectasias, and AVMs.
Classic signs: recurrent nosebleeds, often start young, plus those red spots, telangiectasias, on lips, mouth, fingers.
Diagnosis: clinical, using the Curacao criteria. Remember, ET visited family, epistaxis, telangiectasias, visceral lesions, family history. Need 3 for definite.
Investigations: imaging, CT, MRI, to find internal AVMs. Genetic testing to confirm and for family screening.
Management: control bleeding, iron, local measures, tranexamic acid maybe. Treat AVMs, embolization often key. Regular screening is vital.
Prognosis: generally good if managed well, but serious complications relate to AVMs in brain, lungs, liver, gut.
Perfect summary. Ready for one last quick-fire case?
Let's do it. Okay, 45-year-old woman, known HHT, diagnosed 10 years ago, comes in complaining of increasing shortness of breath over the last few months, especially when climbing stairs. Feels more tired than usual. What's the most likely cause related to her HHT, and what's the key investigation?
Okay, note HHT, progressive shortness of breath on exertion. Top of the list has to be pulmonary AVMs causing shunting, possibly leading to lower oxygen levels or increased strain on the heart.
Makes sense. And the investigation.
You'd want to look for those pulmonary AVMs, so contrast-enhanced CT chest, or possibly a bubble contrast echocardiogram.
Excellent. See, it connects back, symptoms pointing towards a specific organ complication.
Precisely. And finding and treating those PAVMs could make a huge difference to her symptoms and long-term health.
It really drives home that HHT isn't just superficial, it's systemic and needs that deeper look.
Absolutely. Recognizing the pattern, applying the criteria, and then thinking about the hidden internal risks, that's the key. It's a condition where early diagnosis and proactive screening based on that genetic risk can genuinely prevent life-threatening events. Thinking about screening asymptomatic family members once you identify that gene mutation, it's a really important aspect of managing this condition. Something definitely worth reflecting on.
A very important point to end on. This has been a fantastic deep dive, really focused and high yield for MSRA prep on HHT. I hope you listening feel much clearer on it now.
It was helpful.
For more free MSRA revision resources, definitely visit freemsra.com, and for the full premium revision toolkit, you can head over to passmsra.com.